So in the first half of this talk, I'll be focusing on imaging evaluation for patient and device selection. The second half of the talk will be dedicated for TE guidance for transcatheter tricuspid valve intervention, highlighting edge-to-edge repair. As we know, there are many devices out there nowadays to treat tricuspid regurgitation, but it's important to differentiate those that are designed for transcatheter repair than those that are designed from transcatheter replacement. And as I move along today's talk, I will be initially focusing on patient evaluation for transcatheter edge-to-edge repair, and then if not feasible, replacement. Usually a stepwise approach is undertaken, initially with echocardiographic assessment, which is often sufficient to determine candidacy for edge-to-edge repair with either the TriClip device from Abbott, shown down here on the left, or the Pascal device from Edwards, shown down here on the right. If edge-to-edge repair was deemed not feasible and transcatheter replacement was deemed necessary, often a CT scan is required for anatomic assessment for either an orthotropic valve that sits within the tricuspid annulus, like the Evoke valve from Edwards, shown here on the bottom right, or a heterotropic valve, if not feasible, which sits in the superior inferior vena cava, like the Tric valve, shown here on the bottom left. Echocardiographic evaluation starts with transthoracic echocardiogram, and you want to visualize the jet from all possible angles, including parasternal long and short axis view, as well as your apical window. And the goal here is that you want to assess the mechanism of tricuspid regurgitation, being functional in more than 90% of cases, and you also want to assess the chambers around the tricuspid valve, looking at right atrial enlargement, RV dysfunction. Don't be afraid to use your 3D probe. Sometimes the tricuspid valve is in anterior structures, and sometimes you can get a beautiful 3D image that even exceeds in quality or 3D image that you obtain from a transesophageal assessment. And you can use that to assess the morphology of your leaflets, presence or absence, and location of a coaptation gap. Assessment of your inferior vena cava and your hepatic vein is mandatory as part of any assessment for tricuspid regurgitation, and the presence of systolic flow reversal in your hepatic vein is consistent with more significant TR. Shifting your Nyquist limit to measure a PISA to obtain an EROA in a regurgitant volume is a standard method for assessment of TR severity. I also like to use this biplane function, as if available in your echocardiogram system, to look at your vena contracta at two different angles. And even better, if you can use your 3D probe to obtain a 3D vena contracta, which takes into account the irregular orifice often found in patients with tricuspid regurgitation. As we know, there's a new classification theme for TR that breaks down severe TR into severe, massive, or torrential, and you can obtain or complete this assessment by using your PISA-based measurements with EROA, regurgitant volume, but you can also utilize your 3D vena contracta to stage your or classify your TR. It's important to realize that as you get more and more severe TR, you tend to underestimate your PA pressures by echocardiography, and therefore a right-sided heart cath is often a standard a step in evaluating patients prior to transcatheter repair or replacement. As we all know, patients with severe pulmonary hypertension, especially precapillary pulmonary hypertension, tend to have poor outcomes. Next is doing a TEE, which is mandatory for all patients prior to a transcatheter evaluation. We tend to visualize the valve from all different angles, 0, 30, 90, 120, and so on. And the idea here is we want to assess the mechanism of tricuspid regurgitation and to confirm the severity of tricuspid regurgitation. In my view, the most important view is going to be your mid-esophageal inflow-outflow view, usually obtained at 60 to 80 degrees. And here at this view, you're visualizing the tricuspid valve at the anteroposterior plane. Anything that's closer to the aortic valve is more anterior. Anything that's further away is considered posterior. And you can use your biplane function in your echocardiographic assessment to look at the coaptation posteriorly, centrally, and anteriorly to localize and grade your jet, but also to look at things like interaction between your lead and your tricuspid valve. Your transgastric view is also quite important. So looking at an en-face view of your tricuspid valve to look at the morphology of your leaflet, also the presence and absence of a coaptation gap, and more importantly, measurement of the gap at your intended target of clipping. So in this patient, they have a bit of a central gap, but actually if you plan to clip in the anterior septal commissure here, for example, there isn't much of a gap and it's quite feasible. So with your echocardiographic assessment, you need to comment on your anatomy of the valve, the mechanism of TR, presence, absence of a gap, and the measurement of the gap, any interaction with your leads. And you also want to look at your acoustic windows, which views are going to serve you best at the time of your intervention. As we know nowadays that a lot of people don't really have a tricuspid valve. Still, the most common is a type 1 valve that has 3 leaflet, but the second most common is a type 3B valve that has a scalloped posterior leaflet. And we know nowadays from certain data that the more leaflets you have, the less likely you're going to achieve procedural success. And if you have a larger coaptation gap and a non-anteroseptal commissure jet, even worse so. The way that you can classify your valve is to first look at the level below your leaflets. You want to find your anterior papillary muscle, which is the anteriormost, usually bulkiest papillary muscle, and then to come up and look at the leaflets themselves. Anything that's between the pap muscle area and your anterior part of the septum is your anterior leaflet. In this patient, you can see that it's scalloped. And then anything between the anterior papillary muscle and your posterior septal leaflet is going to be your posterior leaflet. Utilizing 3D is also quite important and can give you nice images in some patients, different teams like to orient their valves differently. In this case, the aortic valve is oriented at 5 o'clock, giving you a transgastric-like view. The most important thing is to be consistent. Having a nice 3D image can really give you a good assessment of the leaflet morphology and sometimes even interaction with leads. So classification of TR, so as I mentioned, most commonly functional tricuspid regurgitation, which can be atrial functional or ventricular functional TR. That's present in 90% of patients. The remaining patients can have lead-related TR or primary TR. It's important to realize that not every patient with a lead and TR has lead-related TR, and it's very important to study the interaction between the leads and your tricuspid valve. In this patient, for example, they have a pacemaker lead that's just parked in the posterior septal commissure. And as we assess the valve in different views, the tricuspid regurgitation jet originates more centrally. And likely this patient, even though they have a pacemaker lead, they do not have lead-related tricuspid regurgitation. So when it comes to patient selection, it's important to understand the favorable anatomy for edge-to-edge repair. So a patient with a small coaptation gap, less than 7 millimeters, an anteroseptal location of the jet, no abnormal leaflet, and a trileaflet morphology in general tends to have better outcome. A patient with a large coaptation gap, abnormal leaflets, lead-related TR, or poor image quality tend to have unfavorable anatomy for edge-to-edge repair. Every once in a while, we have a patient like this with a huge central coaptation gap, and as I just mentioned, these are patients that are often considered with non-favorable anatomy for edge-to-edge repair, and in those patients, we often think about a transcatheter replacement. And as I mentioned earlier, it can be an orthotropic replacement or a heterotropic replacement. So a CT scan is often required to look at your annular measurements, the right atrial anatomy, RV anatomy, and to look at the anatomy of the surrounding structures, including the angle between the IVC and the right atrium. So the most common cause for screen failure when it comes to these valves is going to be your annular dilatation. This is the Evoke valve from Edwards, for example. The maximum size they have is 52 millimeters. So if you have a patient with a larger annulus than 52 millimeters, they would not be considered candidates for the Evoke valve. So if a orthotropic valve is deemed non-feasible, then you would have to think about implanting a heterotropic valve like the Tric valve. Next, I want to talk about TEE guidance for transcatheter interventions. So I want to start off with a case. This is a 67-year-old gentleman with NYHA class symptoms, with peripheral edema, ascites, minimal response to diuretic, minimal tolerance to other GDMT, including beta blocker and ACE inhibitor. LVEF is 32%, known ischemic cardiomyopathy, and his medications is listed here on the right side. These are the right heart cath parameters, has a wedge of 19, mean PA pressure of 36, and a PVR of 2.9. Their transesophageal echo assessment was consistent with severe functional tricuspid regurgitation. Here's this 3D view of the tricuspid valve. And this is the transgastric view. You can visually just tell that there isn't really a huge coaptation gap. So the patient was discussed in the valve meeting, and because the patient was not really responding to oral diuretics at home, and the patient was quite symptomatic, the consensus was to proceed with edge-to-edge repair with implanting an XTW clip, that's the largest of the Abbott clips, in the anteroseptal commissure. So we usually start the procedure in the bicaval window, that's not shown here, just similar to the mitral valve, and as soon as the clip comes out, I go into this view, the MPR, or multiplanar reconstruction. So I build my 3D volumes, I go in here and align my planes so that I create almost like an inflow-outflow view in the green box. This allows the interventionalist to really view their entire catheter and the clip. It allows them to align their clip with the valve as well as adjust their orientation before diving into the valve. I stay in the same view as they cross the valve, as well as when they're readjusting and rotating their clip below the valve into the anteroseptal commissure. Now keep in mind, these patients with severe TR, they really have congested GI tracts. And if I have a good 3D view and I can obtain a good MPR, I can avoid going in and out of the stomach and avoiding potential injury to their GI tracts. Once I'm happy with the orientation and rotation of the device, what I often do is I go back to 2D with biplane. And what I do in this view is just confirm that the leaflets are actually inserted. They're up and over the arms. They're down the apex of the clip. And once we are happy with this, we close the clip under color, as shown in this video. So you can see here the clip arms are already closed. The clip is still attached to the catheter. And at this point, we start evaluating our valves, look at the residual TR. I go back into my MPR and just ensure that there's a good tissue bridge. And once we are happy with the residual TR and the result, we can let go and release the clip as shown here. You can see that there is a stable clip with good insertion of the septal and anterior leaflet. The patient was deemed to not have any significant tricuspid regurgitation. This is graded as mild to moderate, and we deemed that a single clip is sufficient in this case. There's a few maneuvers that you can do to reduce the gap. That this can assist you during your edge-to-edge repair. This small study has shown that if you shift the patient 10 degrees, so this is the head of the patient, this is their leg, you can mind the gap. You can reduce the gap size, and you can also reduce the gap area, potentially facilitating your edge-to-edge repair. This is a study that I have led, actually. It was just published 3 months ago in JACC Interventions, where we took patients who are planned to have a transcatheter tricuspid valve replacement and did some inpatient diuresis. So the average diuresis time was about 4 days. Average dose is about 80 millimeters of Lasix. If they were on metolazone at home, we would continue the metolazone. And as you can see here that we were able to reduce the severity of the TR, the annular parameters. Also, numerically, there was a reduction in the PISA, EROA, and regurgitant volume, despite the lack of statistical significance. And also, we significantly reduced the central ancoaptation gap. So this can give you some potential in actually assisting you at the time of edge-to-edge repair. On the right side, this is an extreme example of a patient who was actually coming to hospital for an EVOQUE valve from Edwards. So you can see that on the top, there's a huge coaptation gap. With 4 days of inpatient diuresis, despite maximal doses at home, the patient lost his gap. Like there's no central gap, there's no anteroseptal gap, and we actually ended up aborting the procedure. We did not go ahead and put in an EVOQUE valve. So the same concept follows for any other intervention for the tricuspid valve. So this patient is going for a cardio valve. This is a transcatheter tricuspid valve replacement, and we use the same views and the same principle. So I use MPR, and you can see here, this is the short axis, almost of the valve, and what I do is that I basically adjust my planes on every single ventricular arm of the valve as the interventionalist is deploying the valve. And I look here on the top right and ensure that all the leaflets are up and over the arms as the valve is being expanded. So all interventions of the tricuspid valve are echo heavy, and echocardiography does play a huge role. The same thing applies for other procedures, for example, like sapien in a ring or angiovacing a valve with endocarditis. Again, we use the same views. This is the patient after deployment of the cardio valve, and the nice thing about transcatheter tricuspid replacement is you obliterate the tricuspid regurgitation, and you acutely increase the cardiac output. Often these patients have a couple of days of a polyuria syndrome just from the increase in cardiac output they get after a transcatheter replacement. This is a different patient who underwent an EVOQUE valve. And you can again see the obliteration of tricuspid regurgitation. Notice the pacemaker lead here. This is often the procedure of choice in patients with lead-related tricuspid regurgitation who are not candidate for repositioning of the lead or surgery. 4D ICE, or ICE. So intracardiac echo can be quite helpful in the tricuspid valve. So the tricuspid valve is in the far field, and it's subject to shadowing from the left side, whether a patient has a lipomatous interatrial septum, has a mechanical valve. This often shadows onto your tricuspid valve, and sometimes you have issues confirming the insertion of the leaflet in the clip. And if that's the case, intracardiac echo can be quite helpful as it's much closer to the valve, and it's in the direct line of sight of the echo probe, and it can really help you confirm the insertion of the lead into the clip. This is an example of a case where 4D ICE was used, and you can see that this can, you basically use MPR to align your planes on the clip, and you can confirm, for example, in this case on the left, that the leaflets are up and over the arms of the clip. The grippers are still up here, and on the right side, this basically is the same view with the grippers lowered down. So in conclusion, echocardiography is the backbone and initial technique for tricuspid valve evaluation. High-quality assessment highlighting the mechanism of TR, tricuspid valve anatomy, is mandatory, and excellent TE views are needed for tricuspid valve interventions. Echo screening is sufficient for edge-to-edge repair, but if you're planning to do any other procedure, then CT scan planning is required. And a tailored patient-centered approach is recommended for each patient, but often we consider repair, and if not feasible, we move on to replacement. There are several tools that are available and useful for procedural guidance. So 3D MPR, especially in tricuspid interventions. Imaging the valve at different planes. Deep GE junction views can really bail you out when the views are very difficult. Intracardiac echo, and also transthoracic imaging. Believe it or not, sometimes your transthoracic probe can prove that the leaflets has been appropriately inserted, like the septal leaflet, for example, when both ICE and TE may not have been helpful. It does happen rarely. Few maneuvers are available to facilitate your edge-to-edge repair, including patient positioning, and as I mentioned earlier, pre-procedural diuresis. Thank you so much. Yeah.